So, good evening, doctors. We are going to start a nationwide learning session today on case number 92, which was posted on cghsclinics.com. This was a case about elderly pensioner who came to wellness center with anemia and weight loss. So, this was the case capsule. This case was sent by Dr. Vinita Kaushik from wellness number 2. He was a elderly pensioner with a progressive weight loss since 6 months, because I saw this case in June, and he was also having a mild dry cough since 2 weeks. He denied any fever, vomiting, joint pains, or dysphagia, and he was put on iron tablets to correct his anemia since January. His stools were intermittently black. That's what he described. We don't know whether it is because of the uh, tablets he was taking, or was there any disease process. On examination, nothing but a pallor, but there was no lymphadenopathy. There was a left hypochondriac tenderness, but one finding that we did not give in CGHS, this case capsule, is we actually had a small lump in the epigastric region. But we wanted to explore the possibilities by the doctors. So we kept this finding little away from the history in the quiz. But there was no lymphadenopathy, and his hemogram showed over the last 6 months uh, hemoglobin level between 9 to 10 and 11. And he had on investigation, the last investigation that we did, CT abdomen, he was having a left pleural effusion. And that's the reason why he's having dry cough. So we asked 3 questions. What is your provisional diagnosis? And what investigations would you do next? And whether you agree for hemoglobin electrophoresis, or whether you wouldn't like to do in this patient. So I'm going to run through the presentation. Few of the doctors did respond correctly by pinpointing towards a possible diagnosis, and many of the doctors did gave correct answers. So anemia is very common in aging pensioners, and we tend to sort of don't give much of importance whenever they come in a busy wellness center. But remember, the anemia has a cause in 80% of the patients, and in some patients you can't identify the cause. This is a very important statement made in the American Family Physician Journal. So what common causes patients comes to wellness centers that we find them after investigation? The commonest, of course, gastrointestinal bleeding, then chronic kidney disease, iron deficiency anemia because of GI bleeding, or because the patient is taking analgesics for osteoarthritis, or they are on aspirin because for ischemic heart disease. B12 and folate deficiency to some extent does contribute in our wellness centers, but most important diagnosis are these hematological malignancies and myelodysplastic syndrome, which has worse prognosis. So remember, these patients can come with these possible uh, diagnosis in wellness centers, and you have to know what's the cause. Just don't neglect it. So it is not an aging problem, it is definitely pathological, and a search should be made. So this is a very nice chart given in American Journal of Hematology uh, about how do we proceed whenever we have a patient of anemia in wellness center. So first we look at the iron status, and if the iron status says this is iron deficiency, then we appropriately treat with oral or intravenous iron. But in case if it not an iron deficiency and you see the creatinine is high, the GFR is low, then you're probably dealing with a chronic kidney disease resulting into anemia because of chronic disease. Simultaneously, you can do a B12 or a folate. If it is found low, that's the cause you find. But if that is normal, this kidney function is normal, the iron status is okay, then probably some sinister causes like hematological malignancy or myelodysplasia, these are the uh, uh, diagnosis you should entertain and proceed with the hematological, aggressive hematological reference. Some patients you may not have a diagnosis at all even after you do plenty of investigations. So common that we face a difficulty in these patients is whether the anemia, if it is because of anemia, because of iron deficiency or because of chronic disease. There are important differences that anemia in chronic disease is rarely below 10 grams. It is microcytic, but maybe normocytic. It does present similarly to the iron deficiency anemia as a low serum iron, which is common, but the important differentiation is that total iron binding capacity in iron deficiency anemia is very high, more than 400, which is almost normal in chronic disease. The ferritin, if it is the inflammatory state, may be above 100 in anemia of chronic disease, but in iron deficiency, pure iron deficiency, it will be always low. We commonly jump to the bone marrow biopsy when we don't find any cause for anemia in these patients, but there are some definite indications for diagnosing a cause of the anemia in elderly. The one is definitely a pancytopenia. If you don't have an obvious cause like B12 or some other viral etiology, then another is monoclonal gammopathy, which you can know by doing serum protein electrophoresis. If you have a strong suspicion of myelodysplastic syndrome, where all three lines are going down, you don't find any cause, then if you find on peripheral blood smear immature or nucleated red cells, which may tell you that this may be a malignancy, and unexplained progressive anemia. So these are the usual indications for bone marrow biopsy in elderly patient. So what we should start with in our patients, we always should start with a microcytic hypochromic anemia, which our patient had, because he had a low MCV and low MCH. So we should always think about iron deficiency first. And because this patient had epigastric lump, a weight loss, and a microcytic hypochromic anemia, it was pointing towards a GI etiology or gastrointestinal problem. So we should actually advise an aggressive gastroscopy in such patient. So we did go ahead with gastroscopy in these patients. So what are the indications for urgent endoscopy? I'm talking about urgent in the sense you have to bypass the specialist. You don't have to ask anyone whether I should go for endoscopy or not. Any persistent dyspepsia in an age patient more than 55 years of age, if you find, go ahead with gastroscopy. If there is unintentional weight loss of 3 kilograms or more, or epigastric mass, this is what we had in our patients. So that is the reason we went ahead with gastroscopy. GI bleeding, history of melena, unexplained iron deficiency, which is not getting corrected, dysphagia, odynophagia, persistent continuous vomiting, and epigastric pain, which is severe enough, requiring hospitalization. So these are the indications for urgent endoscopy. You should not wait for any specialist referral. This is according to the British Society of GI management guidelines. So what our patient had an MCV of 76, even lower sometimes in some of the hemograms, low MCH, but his hemoglobin has touched already 10.4 in one report. So at this age, somebody who's having already 10.4, unlikely he has any beta thalassemia trait or any major thalassemias. So I don't think hemoglobin electrophoresis is required in this case. It should not be done, not indicated. And because our patient had certain signs like weight loss and pleural effusion, this points to something else. So we should always go ahead with gastroscopy and search for the cause, focusing on the GI. So this was the reason why we went ahead, and this was the outcome in our patient. The gastroscopy showed a proliferative lesion in the cardia, fundus, and the bodies. It was along the wall, greater wall of the stomach, and it was not very obstructing in nature. Then CT abdomen, which was done simultaneously, showed lots of lymph nodes in along the laser curvature of the stomach. There was even aorta cable, aortic, and common iliac vessels, lymph nodes. So there were plenty of lymph nodes uh, and this growth. So whenever you have lot of lymph nodes and growth along the stomach wall, you should think about lymphoma, malignant gastric, primary gastric lymphoma. And this was what biopsy strongly suggested. But they also give a differential of adenocarcinoma and requested for immunohistochemistry evaluation to further confirm the typing of lymphoma. And CT and the gastroscopy, they all agreed for a predominantly a strong possibility of lymphoma. And if you see the literature of primary gastric lymphoma, is that if there is a preservation of perigastric fat planes on CT, and there is lot of adenopathy which is necrotic and all over the abdomen, then you should think about primary gastric lymphoma, which is actually a rare tumor in abdomen, usually 1 to 5% of the gastric malignancies, and stomach is usually the site of primary gastric lymphoma. Common association is with H. pylori and HIV, which is very well known. And this is the reason why we should uh, actually go aggressively for GI endoscopy in such patients. So what are the pitfalls in the wellness center that we might encounter dealing with such kind of case scenarios? So the patient of anemia, he can be seen by many doctors at different times. Same doctor may not be following up. This is very common. So what happened previously in previous months may not be, entertained much in a busy wellness center. So whether he has corrected the anemia, whether there is rise in hemoglobin, whether he's going downhill, if a doctor sees him for the first time, it may not strike him that well. So he may miss some of the red flags which were there in these patients, like weight loss and when a fluctuating anemia, which was probably partially responding to oral hematenemics. Then there is a misconception amongst doctors that anemia is a very common with the age, and with age, always hemoglobin is less. But this is not the case, which I told you in first slide, that 80% of the cases you will definitely find a cause. Then we do too much of deworming. Whenever we find anemia of such kind, whether they are children or old age, that uh, we tend to deworm very often and don't go for the cause of this anemia aggressively, and we just go on doing these hematenemics and deworming. And we disregard if the patient is on a chronic iron tablets, that melena may happen, and this may attribute to iron tablets, but this is not the case. We have to go on details of the history. elderly patients may not be symptomatic till a very advanced stage of malignancy. This is a very common pitfall which we have seen again and again in most of the malignancies. And as happened in this patient, uh, as happened in this patient, that he was not very symptomatic till the last, uh, uh, till he was having a last stage of malignancy. So our diagnosis in this patient was a primary gastric lymphoma. Although we couldn't do a IHC, the reason I will tell you that this patient passed away just recently. We did try to get back to the family, but because he was just passed, the family was in little uh, bereavement phrase, so we didn't want to disturb them. And we strongly feel that this is a case of primary gastric lymphoma, which has presented and can be correlated based on the radiology and histopathology. Uh, we feel sad for this patient because should have been detected quite early, but can happen because the symptoms may not be very classical, and the patient may not be very symptomatic. So this was our case of primary gastric lymphoma, presenting as a weight loss and anemia because of GI bleeding. If there are any questions that I may take on this case, and the forum is open for discussion. Yes. Any questions from doctors attending this session about the case? They want to ask any queries regarding investigations or anything? Please go ahead. Or anybody wants to make any points? And if there are no questions, can we conclude the session? I'll wait for another 5 minutes.
Hello.
Yes, please go ahead. Yes, madam, please go.
Hello, can you hear me, sir?
Yes, very well.
Yeah. So what about that one of the, in case there was no GI symptoms,
Yes.
can we think of multiple myeloma with anemia and weight loss?
We can think definitely whenever we see a patient of weight loss with anemia, hematological malignancy, if I can take you back to the flow chart.
Screen.
Okay, this is the flow chart that whenever we go along this flow chart, hematological malignancy can be entertained in such presentation. That's I think, a valid suspicion. So definitely we can think any hematological malignancy. But what I see in my wellness center is more of a, if there is no iron deficiency or B12 deficiency, or if the kidney functions are okay, then we always think about a hematological problem like MDS, which is very commonly I encounter in my wellness center. And of course, what you have said is a hematological malignancy. But I selected this case because the ultimate diagnosis was surprising one, because I've never seen a primary gastric lymphoma presenting this way. But we did see gastric carcinomas very often with such presentation. What we miss is we don't aggressively push them for gastroscopy. We always tend to send them to specialist, and
Delay.
then gets delayed. And I
Yes.
think with new circular, I hope most doctors on their own will reduce this timing of getting investigated at their own level. and our patient can get faster diagnosis. Any other questions anybody wants to ask?
Sir, hello.
Yes, yes.
Sir,
You can
what
just pronounce your name, please, because I don't see names on the screen all the time, and others may also
sir,
know your name, please.
sir, Dr. Santosh here from Bangalore.
Yes, yes, sir.
Sir, was LFT done, sir? Liver function test.
Yes, liver function was done, and liver function test was normal. And I will tell you the peculiarity of the lymphoma, gastric lymphoma or GI lymphoma is they don't metastasize very early to the liver or the spleen. This is one of the diagnostic criterias. If I can take you to Dawson criterias, these are the criterias which are devised by one of the author who said that if you don't see liver metastasis, spleen metastasis, and the perigastric fat planes are preserved in such a big mass, then you think about lymphoma. So LFT is unlikely to get deranged in such kind of patients. Any other questions? We are coming to close to the
Sir, how do
session.
we go
Yes.
about request for IHC?
IHC is there in our package, sir. So whenever they have the biopsy block, what I do is, if there is a demand for IHC later on after the primary biopsy histopathology, I definitely issue immediately. There are package numbers, and some of the hospitals are doing these IHC studies. So depending on what antibodies they are seen on the immunohistochemistry studies, they can type which type of anemia, what type of mutation the lymphoma has, and what further subtyping can be done. So this is common in lymphoma. So, but probably this patient died before doing this. That is my suspicion, because we didn't want to disturb the family, because he passed away probably very before all these things could be done. And I suspect that he must have died because of hemorrhage or some uh, this CA related complication. I'll put up the update once if the family does come back, because his mobile number keeps ringing but nobody picks up. Probably they are just it was his personal number. The family is probably not answering anymore these phone calls on this patient's mobile number.
Sir, what would be the probable line of management?
Line of
What would be the management?
management. What they have done is definitely a resection, radiotherapy and chemotherapy. I'm not very expert in what oncologies
Yeah.
definitely go for it, but any lymphoma, like you go for a chemo radiotherapy, and after that if required a resection. That's the principle on which these tumors are treated. But considering his left pleural effusion, which I doubt must be a metastatic one, we didn't have a time for a PET scan. I did advise a PET scan. I don't know whether Dr. Kaushik knows about the outcome of further investigation. But he didn't come back. He was probably admitted immediately, and probably it was metastatizing not beyond abdomen and thorax. So I don't know. Only the chemotherapy would have been offered to him, a palliative chemotherapy. That's what I suspect. Any more questions?
So, what is your experience on aspirin-induced anemia in old people, and how
It's very
severe?
common. It's very common.
How severe does anemia goes, and can we just base our diagnosis on a SOB, stool blood positive, and stopping the echosprin and watching, or should we go in for a endoscopy.
What I do is, if there are abdominal symptoms, short duration, and if the patient's history is strong, that okay, this is a tablet which I get burning in abdomen or stomach pain, and if the anemia is there, I stop it. I then do gastroscopy if the anemia is very low, because I
Mm.
want to rule out any large gastric ulcer.
Bleeding also.
Yeah. And then because I want to also take a decision of restarting ecosprin or antiplatelets, so I definitely
Mm.
go with a gastroscopy immediately if the anemia is quite low, if it is dropping below 10. If it is not below 10, I would just sort of stop it for a week if there is no compelling indication to keep it going on. And I review the patient much earlier, not after a month or so. I ask him to come back after a week with a fresh hemoglobin. If it is not further dropping, it has stabilized. If the patient reports there is no more melena now, then I shift the patient to clopidogrel instead of aspirin. And if he's not on aspirin, if he's taking any NSAIDs, then I just warn him about not taking any more analgesic. So it is about going by the history also, but be
Mm.
aggressive in if the anemia is very severe, and if you find something on palpation, if you find some epigastric mass, uh, if there is lymphadenopathy, like sometimes you get left supraclavicular lymph nodes, and if there is anything else like this patient had a effusion, don't wait for anyone. Just scope the patient. That's what I personally follow. Anything? Any more questions? Anybody wants to add from their side? Need not. I may not be the uh, expert sort of talking. Others can also add to the discussion. There's a point made by Santosh on chat that too many of our patients are on dual antiplatelet. Yes, that's. I think they are wrongly on dual antiplatelet. Commonly, the patients who are on who have underwent angioplasty, I think 1 year is the deadline when you should review whether he needs dual antiplatelets. Definitely, I agree with you. The risk benefit has to be considered, especially in elderly. I totally agree with Santosh's observation, and we can definitely at our own level can decide about ongoing dual antiplatelet therapy. I do it very often whenever I get time, when I have time to talk to patient, of course. But this should be done very often in our wellness centers. We can prevent many GI bleeds, many anemias. So that's it. I think so. I leave. I take your leave if there are no more questions. So this was the clinical pearl. Scope the patient as early as possible with iron deficiency anemia, and if you have a wet loss. Thank you very much for attending this nationwide learning session. Good night.
Good night, sir.
Thank you.
Thank you, sir.
Thank you. Bye.